Okay, medicine family. Final one for today, and final part of the respiratory ailments is week 13, lung cancer. So, lung cancer, uh, lung cancer. I made this one ages ago. I think I made it for a summary back in week 13. So I actually didn't have to make this today, but I did annotate it and I did just go through and revise it. So, yeah, just gonna take myself through it and you can come along for the ride. So starting with the risk factors for lung cancer, the most obvious one is obviously tobacco smoking. If you smoke, you literally have a 10 times greater risk of getting lung cancer, which is crazy. And you can also get lung cancer from passive smoking as well, which is where someone in your environment is smoking and you're inhaling that smoke as well. Interestingly, if you're a female, you're actually more likely to get lung cancer. If you live in a place with air pollution, so like metropolitan cities with a lot of high density roads, if you have exposure to radon gas, which can decay into alpha particles, and these can damage DNA. And obviously, occupational exposure, for example, asbestos. So, yeah. If you have a family history of lung diseases, a family history of lung cancer, and also if you yourself have any previous lung diseases, for example, COPD, refer back to my last video, emphysema being an example. Okay, so now I'm going to go through the classification of lung cancer, and note here that I'm talking about primary tumors or primary cancers, as opposed to secondary lung cancers, which can result as metastases from cancers in the breast or the prostate. So lung cancers can be divided into two subcategories: small cell lung cancers and non-small cell lung cancers. Starting with non-small cell lung cancers, which have better prognoses, we have three main types. There's another one called broncholobar cancer, lung cancer, but I'm not going to go through that because it's not in my notes. So, starting with adenocarcinoma, these are very characteristically usually found in the periphery of the lung. So if you're taking a CT scan and it's not really touching, the tumor isn't touching the bronchus, it's most likely going to be an adenocarcinoma. So this is the most common type of lung cancer, and it most commonly affects women and non-smokers. Upon histological section or biopsy, you're going to see glandular proliferation, so that's a dysplastic glands, the production of mucin. I'm just randomly realizing that there are letters missing. And if you do genetic testing, this might be caused by EGFR and ALK mutations. Now, looking at the squamous cell carcinoma, this is the second most common lung cancer after adenocarcinomas, and it is mostly found more centrally or towards the bronchi. So this one is most common in men and in smokers. However, it does have if you're looking at a histological biopsy of the squamous cell carcinoma, you're going to see, apparently, intercellular bridges, as well as keratin curls, and you're going to see that the stain is very eosinophilic, or pink. The mutations that it's associated with include P53, loss of RB, etc. Not going to name all of them. The least common type of cancer and the least common type of non-small cell carcinoma is large cell carcinoma. So it's the rarest. It's usually found either centrally or peripherally, and if you look at it on microscopy, it's going to show up with nesting, rosettes, and palisading. I'll let you look up what that actually means. But the characteristic feature is that you get these really large cells. There's no particular organization of these cells either. So that's our non-small cell lung cancers. And now we can look at the most aggressive form of lung cancer, which is our small cell lung cancer. So these are the most aggressive form of lung cancer. They're the third most common lung cancer after squamous cell carcinomas. And so to take you through them, usually they're involved in ectopic hormone production, which can lead to something called paraneoplastic syndrome, which I'll go through in a bit. 99% of small cell lung cancers are found in smokers. So like 1% of these are found in non-smokers. There's no such thing here as a carcinoma in situ, aka there's no pre-invasive lesion. So once you find it, it's usually invaded already and it has a pretty poor prognosis. It's virtually incurable by surgery. Although I did just read that about 20% of cases are curable, but I guess it depends on how early you catch it. The common mutations are P53 and RB. And oh my gosh, if you look at this histology, it looks pretty messed up. You literally can see no evidence of like normal lung architecture whatsoever. So you get what are known as these small oat-like cells with scant cytoplasm. The nuclei have a quote-unquote salt and pepper chromatin appearance, and that would be better to see if you could zoom up on this very poor quality photo. But I guess chromatin is the indicative of like a high mitotic rate. Which is also here. You also get a high mitotic rate and molding. And you get a lot of variation between cells or pleomorphism. Now, alright. Oh yes, and they can also be arranged in sheets. Okay, now in terms of signs and symptoms of lung cancer, some of them are pretty non-specific, but when combined with the constitutional symptoms of fever, weight loss, and night sweats, and tiredness, you can pretty much send them for a chest x-ray and perhaps a lung biopsy. So the signs and symptoms include cough, dyspnea, coughing up blood or hemoptysis, wheezing crackles, chest pain, but only if it's invaded into the pleura because the lung tissue itself doesn't have, pain sensors, pain nerve endings. It can cause weight loss, fatigue, and dullness to percussion due to the fact that there would be a mass. Now, looking at the cough reflex itself, I'm just putting this in because, I guess, something that I just learned and I just added it in, and it's an exam question, or possible exam question for us. So this is how the cough reflex works. You get mechanical or chemical stimuli in the respiratory tract. And then this is sensed by receptors which line the respiratory tract. And I just wanted to note that these, there are no receptors in the alveoli or terminal bronchi. So say if you had an adenocarcinoma that like was in the periphery, it would have to be the mucus produced by the adenocarcinoma, which travels like up into the bronchi and stimulates your cough receptors. So once those receptors are stimulated, they send an afferent nervous impulse to the medulla where the cough center is, and then there's an efferent signal that's sent to the muscles of the respiratory tract to close the glottis, and to expire really quickly, which is why you get that explosive cough. So these are your intercostal muscles. So they all contract. Now, metastases in lung cancer can lead to a bunch of different presentations. And of course, this is most likely in small cell lung cancers and is possible in the others as well. So maybe starting from down here. So if you get invasion of the lung cancer into the diaphragm, you can get diaphragm paralysis, which can contribute to your dyspnea. If you get invasion into the pleura, this can lead to pleural effusion and sometimes atelectasis or collapse of a lobe. If the superior vena cava becomes compressed by the tumor, you can get Pemberton sign, indicative of an superior vena cava syndrome, aka you lift your arms up, your superior vena cava becomes obstructed and your face goes all red because the blood can't drain out of your upper limbs. If your recurrent laryngeal nerve becomes compressed, this can cause hoarseness of the voice. If there are metastases to the brain, this may manifest as confusion, headaches, seizures, and personality change. If there's compression of the sympathetic ganglia, you'll get Horner's syndrome. And this is an important thing that we look for in the respiratory exam. We look for partial drooping of the lid or ptosis, meiosis, which is a fixed dilated pupil, and anhidrosis or lack of sweating. And this is due to the possible compression of the superior cervical ganglion by a lung tumor, an apical lung tumor. You can also get obstruction of the esophagus, leading to dysphagia, and airway obstruction, leading to pneumonia, and chest wall invasion, leading to rib destruction. And I wanted to note here as well that lung cancers and the treatments for them do predispose you to respiratory tract infections. A thing that you might also see is lymphadenopathy, or enlargement of the lymph nodes. This would appear in a bunch of places. Usually starts with the hilar lymph nodes, can appear in the paratracheal lymph nodes and the mediastinal lymph nodes. And the lymphadenopathy, which indicates kind of lymphatic invasion of the cancer, helps with our staging of the cancer. So I'll go through that in a bit as well. Before we go through staging though, I wanted to mention paraneoplastic syndrome, which is something I only hardly understand. But basically from what I researched, it's where the cytokines that are released by cells and the hormones that are released by lung cancer cells start creating these syndromes that aren't caused by the tumor cells themselves, but rather the dysregulation of the hormones and cytokines in the body. So you might see in squamous cell carcinoma, an elevated, like the squamous cell carcinomas themselves can cause ectopic production of parathyroid hormone, which leads to hypercalcemia. And this can lead to a bunch of different symptoms, like, for example, kidney stones, confusion, constipation, and lytic lesions in the bone pains. You might, in a small cell lung cancer, get ectopic Cushing syndrome, so the excess production of cortisol. You might get the syndrome of inappropriate ADH release, or SIADH, which can lead to hyponatremia and electrolyte disturbances, which can cause a bunch of things, but can also change your cardiac function. You can also get something called Lamberton-Eaton syndrome, which is where you get antibody-mediated muscle weakness. And then in non-small cell lung cancers, you can also get hypertrophic pulmonary osteoarthropathy or wrist tenderness. And that's something that we also look for in our respiratory exam for OSCEs. Now, in terms of diagnosis, the number one thing that we would do first, then the least invasive thing, would be a chest x-ray. And depending on the nature of the lung cancer, this will manifest and result in different chest x-rays. So there's not one chest x-ray image that we can study. But some things that might be seen in a chest x-ray of someone with lung cancer are lobe collapse or atelectasis. And we might see a mass, whether or not this is peripheral like this or central like in this photo, remains to be confirmed. However, 60% of masses are peripheral. You might also get the elevation of the hemidiaphragm and pleural effusion as evidence through the blunting of the costophrenic angles. On a CT scan, which is a nice transverse section of the body, you can look for the lung mass, and you can also look for any metastases. As well as this, we can perform a sputum cytology to rule out any infectious causes, and a biopsy. So the biopsy is how we basically work out what kind of lung cancer that's they have and how invasive it is. And if it's a more centrally located lung cancer, for example, squamous cell lung cancers or large cell lung cancers, we can actually do something called a flexible bronchoscopy, which is basically where they stick a tube down into the lungs and they take a swab or a little biopsy of the lung tissue and sample that. It can be pretty invasive though. In the case of more peripheral tumors, such as adenocarcinomas, you can actually go from the outside of the skin and go transthoracically to take a needle aspirate of the lung tissue. It's important to note though that a negative lung biopsy does not exclude disease, because sometimes the cells are so small or the tumor is so small that you might completely miss the malignant cells. You can also do a spirometry to assess their lung function, although it's not diagnostic. You can do a CT to determine spread, an FBC to look for anemia, LFTs to look for metastases to the liver and bone, and an electrolyte level to look for paraneoplastic syndrome. So once that's been diagnosed, we can go on to stage it. So for non-small cell carcinomas, we can use the TNM, or tumor node metastases system. Whereas for small cell carcinomas, because they're so progressive and so invasive, we don't use the TNM staging. So basically, for the TNM staging, we first look at the tumor. A T1 corresponds to less than 3 centimeter size of tumor without pleural involvement, whereas a T4 indicates invasion into the mediastinum, the heart, and the spine. And that's on a scale. So T1, T2 would be a little more invasive and a little bit bigger. T3, even more, and T4 is invasive. In terms of nodal involvement, 0 indicates no node, so no lymph nodes. 1 indicates a singular ipsilateral node. 2 indicates multiple ipsilateral lobes, and 3 indicates contralateral nodes involved. And then metastases is just 0 or 1. Oh. So you either get no metastases or distant metastases. So say you had someone who had a tumor that was 2 centimeters and you had bilateral lymph node involvement with no metastases. They would have a tumor grade of 1, a node of 3, and a metastases of 1. So T1, M3, M0. Now looking at small cell staging, you only have limited or extensive. Limited is where it's been confined to regional lymph nodes and it's only on one side. So you have about an 18-month prognosis. In extensive disease, you would get beyond regional lymph nodes and your prognosis decreases to about 9 months. So as you can see, small cell carcinomas are pretty shitty and they're very aggressive, and that makes me very sad. So for treatment, again, this is divided up into non-small cell lung cancer and small cell lung cancer. So for non-small cell lung cancer, if you have stage 1 to 3, where we only had the involvement of the lymph nodes on one side of the body, you can do a surgical resection in the form of a pneumonectomy, which is where you remove the entire lung, or a lobectomy, which is where you just remove the affected lobe. And you would also administer adjuvant chemotherapy and radiation. So that's for the less invasive lung cancers and a lower stage. However, in small cell lung cancer, which is more aggressive, and the more advanced stages of non-small cell lung cancer, which is where you might have contralateral node involvement and metastases, perhaps, you would not do, it would be more palliative care, and you would not do a surgical resection because that would be pretty useless if you have a cancer that's already spread. So what you would do is you would give them chemotherapy and radiation in the form of cisplatin and carboplatin, which are alkylating agents that bind to DNA and basically stop DNA replicating. But from what I hear, they have pretty bad side effects, like the nausea, the vomiting, the hair loss, etc. is pretty bad. So, yeah. Anyway, that made me kind of sad. Yeah, that's lung cancer, and it's a really, really big disease. I think in 2011 it was like the 5th most common lung cancer, but it is the number 1 cancer that causes the most deaths in Australia. So, stay safe. Try to quit smoking if you smoke. And thank you again for listening to another Val Disease summary video. Goodbye!